Hello, everyone. Hello. Thank you so much for coming. We're really glad to have you here today, both on Zoom and in person, for this hybrid Institute for Addiction Science speaker series. My name is Adam Leventhal. I direct the Institute. Before we get started, just a little bit about our institute. We are a university-wide initiative here at the University of Southern California. And our institute focuses on stimulating collaborative interprofessional research programs, community engagement programs, and education programs. And so as part of our mission, we like to get some of the world's leading experts on key topics to help disseminate some of the science on really, really important issues. And that's why we're here today, and we're really pleased to have Dr. Jennifer Havens from the University of Kentucky presenting. So a little bit about Dr. Havens. She is currently a professor in the Department of Behavioral Sciences and the Center for Alcohol and Drug Research at the University of Kentucky College of Medicine. She trained in infectious disease epidemiology and at Johns Hopkins, Bloomberg School of Public Health. She's been continuously funded by the NIH since 2008, which is hard to do, and well-funded too, I should also add. And so her studies look at the infectious complications of drug use among Appalachian populations. And she's the PI of a NIDA-funded longitudinal cohort study of people who use drugs, as well as another NIH-funded hepatitis C micro-elimination trial. And one of the things really impressive about Dr. Havens' research is, she's been following some of these populations for more than a decade now. Her retention rates are really high. And so that's really important. It just speaks to the quality of her research and her ability to, work with really, really important underserved populations, one of the few, I think, research teams in the nation. So she has a lot of expertise in a number of different areas. Today, she'll be focusing on some of her key research, and she's published many papers, more than 120 papers. She's well decorated at her university in terms of awards and also in some of the national societies. On the editorial board of the prominent journals in our field, and impressive as a panelist in many federal venues, which I think is really, really important in getting the word out and not just keeping the data in the ivory tower. So anyway, we are really excited to have Dr. Jennifer Havens. And just one final note before we give her a nice round of applause to welcome her. We'll have a talk. If you have questions online, you can put them in the chat and we'll do questions at the end. And then afterwards, there'll be a lunch. And then I believe there may be a trainee meeting. So if you're a trainee and you have questions, come and talk to me or Vicki afterwards. But anyway, let's welcome Dr. Havens.
So much. I'm gonna adjust that just a little bit so you can see me because I'm shorter than Dr. Leventhal. Thank you so much for that introduction. I really appreciate it. And I'm really excited to be here today at USC to talk a little bit about our neck of the woods, which is rural Appalachia, which you probably don't hear a whole lot about in Southern California. So just to give you some, let's see if I can make it go.
Click the slide plus.
This one.
Click the slide, and it should work.
Oh, just on that.
Yeah.
Okay.
You're on those things. Cool.
Oh, there we go. So just to give you some geographic context, I start most of my talks that are not in the state of Kentucky with this slide to give you an idea of the geographic area we're in. So this is from the Appalachian Regional Commission. It's a federal organization that is really focused in on this area of the country. And they do annual assessments of the economic status of the Appalachian counties in this part of this region of the United States. And you'll see that they're colored differently, the counties individually, and that is a 3-year average unemployment rate, per capita market income, and poverty rate compared to the national averages. So you can see that the area I have circled, the longer skinny county is Perry County, where my studies are. And it's in one of these areas that has high economic distress. So these are amongst the 10% of the poorest counties in the United States. So if the numbers don't speak to you, potentially a photograph will. So this is, although it is a stock photo, I've done enough home visits to know that unfortunately this is not the exception, but oftentimes the norm in terms of living conditions. So you can see a trailer home, oftentimes there will be a creek bed behind it. And you may be aware a couple of years ago, there was some catastrophic flooding in that region of the country. And these trailer homes were picked up by the floodwaters and literally just taken downstream. And many don't have running water, don't have electricity. There are often 7 to 10 folks living in a trailer. You can see there are not windows, so they're not protected from the elements. This is up in the mountains, so it's a colder region of the state as well. So this is an area that has very high poverty rates. And I think that you can see from this picture, this unfortunately is the majority of the folks enrolled in our studies are living in conditions a lot like what we see here. So just to give a little bit of context, now there have been many books and many series now on television that probably have made you very well aware of what was happening in Eastern Kentucky. So rural Appalachia was the true epicenter of the opioid epidemic. It's where it began, and that's probably why it took so long for it to be recognized, right? Because most drug use trends don't start in rural Appalachia. So it took a lot to get the word out there and to say, hey, this is a problem, and this problem is likely not going to stay in rural Appalachia. It's likely going to expand out. And once it started to do that, that's when there was a lot more traction. So it was truly a perfect storm, right? So you had the Joint Commission recognizing pain as the 5th vital sign, and as a result, there was more promotion of opioids to treat pain. And then the two that kind of really fall firmly on Purdue Pharma, the very aggressive marketing of OxyContin and downplaying the addictive properties to the providers. So a lot of these providers in these rural areas, they may be the only physician in town, and they have a lot of folks who are in chronic pain, who are in pain, and they're being told that this is a miracle drug that's going to help everyone in their community. So they're out prescribing it to folks. And oftentimes they didn't figure out how problematic this drug was until it was too late, until there were a rash of overdoses. You know, if you're a town of 400 or 500 people and 10, 20 people are overdosing, that's a huge swath of your population if you're actually looking at it from a rate wise. And then the Appalachian culture, and I can talk a little bit more about that. So this area was absolutely ripe for exploitation. And somebody, I think at Purdue Pharma, must have done their homework to figure this out, because already there was a culture established that if you're in pain, you get a pill and you get an opioid. So the coal camps, this goes back to the coal camps. So mining is very prevalent in this part of Kentucky. There are, when we started the study, there were 5 mines open, and I think we're down to 2. But if you know anything about coal mining, oftentimes if there was a coal miner in the family, they would support the entire family and the extended family because it actually paid fairly well for that part of the state and that part of the country. So if the miner went down, so went all of the income. So there was a concerted effort to keep the miner in the mines. So at the coal camps, they would hand out opioids like candy to keep the miners mining. Otherwise, there wasn't coal coming out of the mines. And then the other industry in that part of the country, it's heavily forested, is lumber. So again, a very laborious industry where there's a lot of potential for chronic pain. And given that we'd already established that culture in the camps, that if you are in pain, you get a pill, you get an opioid, that was also combined with the fact that there was already this culture around sharing. So if grandma has a prescription for Oxy, we all have a prescription for Oxy. So they don't necessarily view that from the legal standpoint, that really that's not their drugs. They think that if it's in the family, that everyone can share in the drugs. And then the safety, it was coming from a physician, so why wouldn't it be safe, right? So they put a lot of trust in their local providers. And that's, I think, kind of all of these factors came together, and it really was truly a perfect storm in an area that was completely ill-equipped to deal with the onslaught of problems that arose as a result of the epidemic. So again, there's been books, there's been editorials, now miniseries, and I think, again, it was unique. It was a unique story because most of these problems don't begin in such humble rural areas. So I think that that's why it's kind of it's become very compelling, from obviously for entertainment as well as, but you know, we're in those communities every day, and they have not recovered. They've never recovered. There are entire counties in Eastern Kentucky where more than half the children are being raised by custodial grandparents because the parents are dead, or they're in jail, or they've lost full custody of the children, and they'll never get them back. So the results, or the consequences of the opioid epidemic, are going to be felt in these communities for decades to come. So in terms of our particular cohort, so we're in that little circle, Perry County, Kentucky. So certainly OxyContin. When we started this study and we did some of the prior work, Oxy was the end all be all. If they could get their hands on an Oxy, that's what they wanted. That was the drug of choice. The progression from, oftentimes with opioids, move from oral to smoking to injection was very quick, because you got a lot more bang for your buck if you were injecting Oxy. Oxy in its heyday was going for $2 a milligram, and the most popular pills were 80 milligrams. So $160 for one pill in a very impoverished area. That led to a lot of sharing of the drugs, which is why we're going to talk a lot about hepatitis shortly. But again, the problems that were not foreseen, this was previously an injection naive community. So to have all of a sudden go from very little injection drug use to a high prevalence of injection drug use because of OxyContin was overwhelming for most of these communities. The FDA cracked down on Oxy. It was taken off the market. Well, folks were already used to injecting Oxy. That's a mono formulation, so it doesn't have aspirin or acetaminophen or any other additives. So they were looking for a drug that they could inject that was also mono formulation. So then that's when roxicodone became very popular. And while the pill mills were still open in Florida, thousands and thousands of Roxys were making it back to the streets in Eastern Kentucky. So their immediate release, unlike oxycodone, which is extended release, so they were having to inject more. And they were using a lot of Roxys, or they called them IR30s per day, and injecting more than they were with OxyContin, which, the more you inject, the more you put yourself at risk for hepatitis and HIV. So mid 2010s to now, certainly in the rest of the country, we saw that shift to heroin. So you heard a lot about that in many communities. So people were using pain pills, and then all of a sudden they couldn't get opioids anymore. So they were going to the street. You were hearing about folks buying heroin on the street. We didn't really see that in our community. Heroin never really got to us, which is really interesting. I don't know if it's geography. It was the folks that were moving the drugs to the community. We've never really figured it out. You can certainly get it, but it never became the drug of choice. I was just waiting and waiting and waiting because that was happening in the rest of the country, and it just wasn't happening in our area. And the fentanyl is not purposeful fentanyl use. It's just that we now have methamphetamine as the drug of choice, and most of the meth is cut with at least a little bit of fentanyl. And unfortunately, most of the folks don't realize that they're using fentanyl. In fact, we will give them fentanyl test strips. They'll test their meth and are shocked when there's actually fentanyl in their meth. We've had an increase in meth overdoses in the last few months, and when we get the results back, the toxicology results back, more often than not, there's fentanyl present, and they were unaware that there was fentanyl present. So again, one of the reasons that the alarm bell wasn't sounded about this early on is because it was rural areas and it wasn't out in the literature. There weren't a ton of researchers on the ground, you know, when they first got a signal about a new drug. And so they weren't also expecting those consequences that we see in urban areas, which is, you know, prolonged HIV outbreaks, hepatitis C outbreaks. So in Austin, Indiana in 2015, you may have heard about an HIV outbreak amongst oxymorphone injectors. And again, these were all mostly injection naive populations, and their viral loads were crazy high because they were all also newly infected with HIV. So as a result of that infection, or that, outbreak, the CDC did a hotspot analysis. And basically what they found was that there were a lot of communities in rural areas in Kentucky in particular that were at much higher risk for an outbreak of HIV. So they were trying to alert, I think, most of these communities that, hey, you need to be testing for HIV and hepatitis, and oftentimes hepatitis comes first. It's kind of the signal that there's an impending HIV outbreak about to happen. So when they did this analysis, this hotspot analysis, 25% of the counties were in Kentucky. Now, granted, we have 120 counties, so, but you can see most of the eastern part of the state was considered vulnerable to HIV and hepatitis C outbreaks. So we were facing not just an opioid epidemic, but then all of the unintended consequences, right? So now you've got all the infectious complications. So as an ID epidemiologist, I was really interested in how that was going to shake out. And we found that some of our ethnographers went into some of these communities in the late 90s because they were concerned about HIV and couldn't find an injector. I mean, they were trying really hard to find people who are injecting drugs. We go in 3 or 4 years later, and 40% of the people we're talking to are saying they're injecting drugs. A couple years after that, we're at 60 or 70%. So it took off very quickly, unfortunately. And if you are familiar with epidemiologic methods, you know that this is something we use often, these epidemic curves. And the epidemic curves often don't shift, though, very often. And to get a shift in 7 years from this distribution to this bimodal distribution as a result of the fact that most of the new onset cases are in young people who inject drugs versus baby boomers. When you used to hear about hepatitis C, it was all about baby boomers, and there was this real push to get all the baby boomers tested and treated. Well, now the majority of the transmission is in young people who are injecting drugs. So to see this shift in the epidemic curve is just phenomenal. And we saw it bore out in Eastern Kentucky. So as a result of some of that early work we did in 2003, 2004, we were able to get a longitudinal cohort study funded. So I think I'm saying a lot of negative things about rural areas, and I don't want to give the impression that there's not some amazing qualities about our rural people. I think the one thing that stands out to me is their sense of community and the relationships they form with each other. These are lifelong relationships. And there's not a lot of out-migration or even in-migration. So these are people who live in the same communities for life. And so when I thought about those relationships that people have with each other in rural areas, I thought about networks and networks of people. So this was really an opportunity to look at drug use through the lens of social networks. So again, from an ID perspective, I was really interested in looking at hepatitis C and HIV in particular, but again, in the context of folks' networks, because potentially you can also leverage these networks for interventions, right? So we know that oftentimes we associate, drug use obviously is a maladaptive behavior, but we can also encourage behavior to travel positive behaviors. We can leverage networks to spread positive behaviors through them as well. So now we've been following them up. We have an additional 4 follow-up visits. That was the original, was 6, 12, 18, and 24. Now we're on our 9th wave of follow-up with this group. So we've been following them since 2008. We have replenished the cohort a little bit because they age out, and some people don't want to participate anymore. And we've actually now combined another cohort from Eastern Kentucky as well. That's just about an hour and a half north of Hazard, Perry County. So when we started, it was 500 folks who were not in treatment. We just want to say community dwelling. We were really interested to see if they were cycled in and out of treatment over time, which many did. But at the beginning of the study, we were recruiting them from the community. And while the eligibility criteria could have been cocaine, meth, heroin, 99%, this was mid 2000s, so almost everyone was using prescription opioids at the time. So talking about networks, this is our network. So this is our baseline network. So this main component encompasses 75% of the entire cohort. So if you're at all familiar with networks, sociometric networks, most of the time it's a series of smaller components. So this is a very unique situation where we have the majority of folks who have a connection. So just to orient you a little bit, so the dots represent people, the lines represent relationships between people. In this case, the relationship is a drug-using relationship. So we say, we ask them to free list who they're using drugs with, and then we have an entity resolution process whereby we try to determine who that person is and confirm that if they name Joe P. So ideally, Joe P's in our study too, and that's easy because we'll ask, how old is Joe P, gender, things like that, and we are able to use the information we already have from Joe's interview to confirm. But for people who weren't necessarily in the study, it was a little bit more difficult to confirm. So those aren't included. This is only people in our study. So this is connections only amongst people in our study. So the red dots were hepatitis C positive, antibody positive at baseline, and blue were the negative. And then we continue this over time. The yellow dots are incident cases, so seroconverters, people who were HCV negative, who are now HCV antibody positive. And then over time, you just see the vast majority had a direct connection to someone who was hepatitis C positive at a previous visit, and they're using drugs with them, and then they seroconvert over time. So now we're at about 78% seroprevalence in that cohort study. So we took that data and we presented it to a couple of folks. We presented it to Dr. Volkov, who leads NIDA, and Dr. Doug Lowy, who at the time was the acting director of NCI. So we presented these data to them at separate times, and they went back to NIH and said, hey, we should do something about this. So hepatitis C, we're having a hard time addressing the opioid epidemic, but at that time, they were also starting to think about those healing community studies that have then since come about to address overdose. But there was really nothing, no one wanted to touch hepatitis. So basically, the NIAID folks said, that's not really, it's ultimately, yeah, it's an infectious disease, but it's chronic, and then, so they didn't really want to touch it. And NIH hadn't really, they'd done, NIDA had done a lot with HIV, but hadn't really done a whole lot with hepatitis. So we kind of couched it as hepatocellular carcinoma prevention. So if we can treat people's hepatitis C early enough, we're going to reduce the likelihood that they develop HCC. So that's how we couched it with NCI, and NCI has a much larger budget than NIDA. So they were able to work together and co-fund a study, which is ultimately a micro-elimination project. So if we think about eliminating hepatitis C, that is actually an option at this point because of the new drugs. Now they're 10 years old, but direct-acting antivirals, they can actually cure the virus. Before, in the interferon era, you had about maybe a 50% cure rate at best. And folks told us that the treatment was worse than the disease. So a lot of people didn't even want to engage in interferon therapy. So these new drugs, 8 to 12 weeks, all oral, 1 to 3 pills a day, favorable side effect profile, and we can cure people. So once you have a drug that can actually cure folks, you can actually talk about eliminating the virus. So we're actually in in the stage of talking about elimination, and WHO has put out some amazing documents about how we can do that. But if you're talking about elimination, you also have to be targeting the treatment, the curative treatment, to those who are transmitting the virus. And it's people who use drugs, right? So that there is the rub, right? You are having to target a treatment to a population that people generally don't want to engage with, providers included. So this study the goal was to eliminate the virus from the community by basically blanketing the county with treatment and free treatment. So we're screening everybody and treating everyone free of charge. So we don't have to run it through Medicaid. There are a ton of stipulations on Medicaid to be able to treat hepatitis C, and they differ by state. So unfortunately, you could go across state lines and there's a completely different set of rules about who can access hepatitis C curative treatment through Medicaid. So we wanted to remove that piece of it and just say anyone who was interested, who was chronically infected, come to us and we'll treat you. And then we're going to kind of try to see if we were able to reduce the community viral load. So we have published our protocol paper. So if you're interested in kind of the nuts and bolts, it's in BMJ Open. So screening. So this is a community, the county itself, 30,000, but the town is 5,000. We screened about 1,000 people in this community. We just did a brief screening, and basically they were eligible if they're 18 and over and lived in the target community. We obviously are looking at doing a medication therapy, so we needed to get more information. So that required an in-person screening. So we actually do hepatitis testing. So we invited everyone who was at least 18 and a resident of the county to come, and we still had no shows, even though we told them it's okay if you're using drugs, where everything is free. You still have people who don't show up. Even if you talk to them at 5 p.m. and schedule them for 10 the next morning, they still don't show up. So at the end of the day, about half the people who we screened were eligible. So really, again, the only eligibility criteria were that they're at least 18, resident of the county, and they were chronically infected. So they really just had to have detectable viral RNA. And those who were ineligible, so antibody negative or RNA negative, we said, hey, come back every 6 months or so, and we'll retest you, because sometimes they are just in a different stage of the disease. So we invited folks to come back, and I think we ended up enrolling 7 people. That's included in those 380, but who were negative previously and who came back and screened with us. So here's our model of care. So in my mind, I was also thinking, okay, this is Hazard, Kentucky is not the only under-resourced area in the United States that's dealing with hepatitis and dealing with the opioid epidemic, or the unfortunate side effects of the opioid epidemic. So what do many under-resourced areas look like? Well, many of them have, there's a dearth of specialists. So there's not a hepatologist or an infectious disease specialist, but they may have advanced practice providers. So PAs, nurse practitioners. And as our medical system moves to put nurse practitioners and PAs kind of on the front lines, especially primary care, I think I was thinking about how we could potentially export this model to other under-resourced areas. So that was really important. We do have an ID specialist available to us if our nurse practitioners have questions. And then there are a couple of drugs that there are drug-drug interactions with Softbell, which is what we're using. And we just email him. So it's a very easy, little low resource that we need to engage. And if you actually have a pharmacist on hand in your practice, you could actually just consult with them. But for the most part, it's very easy to get folks started. So for that reason, we have streamlined enrollment. So again, if we're talking about an under-resourced area where transportation is a huge issue, I'm going to talk a lot about that. Why do they have to come back 3 or 4 times before you start them on medication? There's no good reason to do that. So for the vast majority of people, we're starting them on the same day. They come in. We have access to point-of-care RNA testing in our clinic. So if they are detected, they have viral RNA and they don't have a drug-drug interaction that they need to consult with their doctor to get changed, and we'll start them on that day. And then we use that regular point-of-care RNA testing, obviously, to determine eligibility, but also for adherence and response. So if they're taking their drug as prescribed, we should see precipitous drops in viral RNA. So we can actually say, hey, you know, the vast majority of people were saying, you're doing amazing, keep it up, because we can see those drops. And because we have real-time data available to us. And we're doing extended follow-up for a couple of reasons. You know, about a third of our folks are active people who inject drugs. So there hasn't been a lot of long-term data on reinfection. So we're really interested in looking at long-term reinfection rates. And most of the clinical trials only follow people up through 3 months. And that also allows, again, just additional contacts with our medical providers, which is great for them. And then we'll refer them to treatment and pay for their MOUD treatment if they're interested. And then we're also kind of toting ourselves as like a one-stop hepatitis shop. So we're doing hepatitis A and hepatitis B vaccinations if we do laboratory testing, and if they are not immune, then we will go ahead and do both of those vaccinations. We provide, when we came into the community and said, hey, we want to do this study, there was not an active syringe services program. And we said, okay, then we're going to take our business elsewhere. And lo and behold, it got approved the next day in the community. So we provide the funding for the syringe, some of the funding for the syringe program. And then we have a social worker who has established a great referral network for services and gets them enrolled in Medicaid. It's not a requirement for the study, but we know that access to the vast majority of other services they may want in the medical community, they need Medicaid. So if they're not already signed up, we go ahead and do that for them. So we're using Softbell. We were fortunate and we received a drug donation from Gilead. So when we wrote the grant for this study, a 12-week course was about $95,000. So obviously that's outside of the of the reach of most folks. And Medicaid was also didn't really want to touch it because it was pricey for them. I realize they get different pricing, but it was still very expensive. Once we started the study, it was down to about 25,000, and that we're anywhere from 12 to 25,000 now, but Medicaid is much more likely to cover it at this point. So we do remind folks to take it every day. So what we do is establish a time of day to take it. So we say, you know, do medications sometimes make you nauseous? Okay, let's take it at mealtime. Do you often get fatigued from taking meds? Let's take it at bedtime. So we will have our reminder correspond with the time of day that we've decided that they should take it. And we can change that. They can call us up and say, you know, it's really not working taking it at 2 p.m. I'd like to take it at 10. We'll change their text reminder. And if they respond to our text every day, we'll give them $1. So they can respond with a yes, a no, an emoji, whatever. We keep track of that. And then the next time they come in, we pay them $1 for every time they respond. And we haven't, that data is separate because it's in a separate system, but I would certainly hypothesize that that's going to be a huge plus in terms of adherence and response. I think our outcomes are going to be far better for those who were responsive to the text messages. Now, cell phone coverage is not great, and the ability to own a cell phone is severely hampered in this population as well. So if they want a landline phone call, we'll do that. If they want, Facebook is huge, interestingly, in this part of the country. And so we have a lot of folks where they friend us, and then we're able to do reminders through Facebook as well. So the reason that the visit schedule is some in black and some in red is, again, we really have to think about the ability of people to get to appointments, right? And if we can streamline how we deliver hepatitis C treatment to people, I think we're going to have better outcomes for the vast majority of folks. So now that we've been in the field for 3 or 4 years now and been doing it, I think the visits that are absolutely required or that are going to be best for outcomes are the ones in black. So you got to get them in and do a baseline. And ideally, if you can start them on day 1, that's great. So in and out. The 2-week visit has been absolutely integral to this study. It's a check-in for everybody. Everyone comes back at 2 weeks. And we can catch people who aren't doing well from the get-go and not get 6 weeks in, and then we bring them back in and figure out they haven't been taking their meds since day 2, right? So now we know we can restart them, I lost my meds on day 3 or whatever. Okay, let's get a fresh start. And then if we need them to meet with the social worker, we can do that. And they can say, hey, what's going on with you? And they may say, well, I had a really rough month. I lost my job or whatever. Okay, let's work with you to get some of these other things back on track so you can be adherent to the medication. And then obviously the end of medication visit at 12 weeks, and then the all-important cure visit, basically SVR. So basically we can say they're cured 12 weeks after their medication completion. If they're still undetectable, we can say that they're cured, and which is the visits that I love to be there for, to be able to tell people they're cured. And especially with people who are using drugs, they have so few wins in their life. This is a huge win for them. And that often puts them on a path to better health in other aspects. They said, oh, I could do this. If I could get through this, I can tackle some other issues in my life. So it actually ends up being, I think, just a really wonderful, even if it's a small piece, and even if they weren't feeling bad, oftentimes they aren't even necessarily feeling bad at this point, but just to know that they're cured of their hepatitis, one issue that has come about as a result of their drug use is wonderful. And these, the 6 and 12 months are really just for us, right? As researchers, we're really interested in kind of long-term outcomes. So those aren't necessary if you're thinking about doing this as part of your clinic. So just our labs, again, we do the point-of-care RNA testing. So we were able to get, so this is not an FDA-approved assay in the United States. So point-of-care hepatitis C testing, Cepheid has a platform, the Gene Expert, which actually, these cartridges, they come for a bunch of other different, so COVID, flu, chlamydia. So the cartridges all fit in the same system. It's just a different assay for each cartridge. So this has been approved in Australia and Europe for years and years and years, but for some reason it's not in the United States. So we were able to get a research exemption. All they asked us to do is basically confirm the hepatitis C result with LabCorp. So we do blood draw anyway, and we send it off to LabCorp. And if we had discrepant results, they asked us to then do further testing. We have had no discrepant results. Not surprisingly, the Gene Expert works fantastically well. And so our positive predictive agreement's 100%. So now we are working with RADx, which is the group that they brought together for COVID diagnostics to really rapidly approve all of those. Remember, you guys all lived through it. You would see new tests coming online all the time for COVID. Well, they needed a mechanism to expedite approval through FDA. So this group was brought together. They're now leveraging this group for this purpose to move this through the system. So we are the only group, I believe, in the United States who has real world data using this platform. So we will be hopefully providing that to FDA. So this is a younger group. These aren't baby boomers, right? So these, the average age is, or the median age is almost 42. We have young people as young as 20. And then most of the older folks, Medicare there's never been an issue with coverage for hepatitis C curative treatments with Medicare. So most of our older folks who are on Medicare had already been cured at that point, or had already sought treatment elsewhere, because there were far few barriers. A couple things I'd like to point out. So third, active people who inject drugs, so mostly methamphetamine. Very surprising. We thought we were going to be doing a lot more referrals and payment for treatment. Almost half came in already enrolled in an MOUD treatment program, which is fantastic. Again, the data, we don't have all the data in yet. But it's trending in the direction that the people who are actively or engaged in an MOUD treatment program are going to do a little bit better in terms of outcomes, but it's not quite there yet. I think once we have all the data, certainly I would hypothesize that would be the direction it would go. But the one I think that's huge for us is transportation. There's no Lyft, there's no Uber, there's no taxi, there's no public transportation. So if you don't have a car, you're relying on somebody else to get you somewhere. And the things that women have told me that they've had to do to get a ride is absolutely heartbreaking. And it's just, they have no other options. We have a van, but our university insurance is not nice about us going to pick people up. But if they need to get somewhere, we end up taking them somewhere because, you know, they need to get, you know, so we've had people who we needed to transport to the emergency department, transport down to the syringe program, you know, as much as we can do. But we're not allowed to go on a regular basis and go pick them up for their appointments, unfortunately. So medication initiation overall, almost 97% initiated the meds. And like I said, at visit 0, that very first visit, 85%. And the reasons they're not. So the one thing about the DAAs, they can reactivate hepatitis B infections. But at the end of the day, if they're on the meds for a few days, if they're on DAAs for a few days, it's not going to reactivate an hep B infection. So really just folks that said that they had been told prior that they had hep B, we waited for their labs to get back to start them, but obviously there were people who had never been told who were hep B positive. And all we did was then we would talk through that with our ID specialist and get them co-treated for their hep B and hep C infections. But that's been one of the issues with doing this kind of streamlined enrollment is people are very concerned about hep B reactivation, when at the end of the day, the actual HBV prevalence was only 1.6%. So the combination of low seroprevalence area and the fact that 4 or 5 days at most of DAAs are not going to reactivate a hep B infection, that really shouldn't be a barrier to doing streamlined enrollment. So loss to follow-up, it's a study, it's a clinical trial, it's part of our lives. But I have a really interesting sort of twist to our loss to follow-up. So the red bars are people lost to follow-up over time, so it's cumulative. And so that's weeks 2 to 4. And the blue bar represents people who are undetected. Remember, we're doing RNA testing at every visit, so we know if they're no longer detected. They no longer have viral RNA, they're not transmitting the virus. So from a public health perspective, this is fantastic. So a third of the people lost to follow-up aren't transmitting the virus, even though we've unleashed them back out onto the world and we don't really know what they're doing. Likely they are no longer transmitting the virus. So even at when we all said and done, the 78 people lost to follow-up, 31 of them were undetected the last time we saw them. So the statistician in me said that this is not good for my outcomes, but the public health practitioner in me says yay. So and these drugs are exceedingly powerful. It's so amazing for having such a, you know, there aren't a lot of side effects, but by 6 weeks, the vast majority of the people are already undetected. So 80% are already undetected by 6 weeks. If we're thinking about this from a public health perspective, again, treatment is prevention approach. If we're talking about elimination, we need to be treating people who are transmitting the virus. That's people who are injecting drugs, right? So these are the people we need to be getting treated. Right now, in conventional standard of care treatment, it's often 6 weeks between their visits before they're even starting the meds. We are already getting them cured in 6 weeks. And think about the potential averted infections from getting them in and starting meds almost immediately. And this includes obviously all of our folks lost to follow-up. So that's why our medication completion rate is only at about 72%. And our SVR rates. So this is the big, when you're doing hepatitis C treatment trials, everyone's really interested in how many people were you able to cure? What is the proportion you're able to cure? So when I say per protocol, so really the very rigid sort of definition of SVR is amongst those who completed treatment, how many of them were cured? So that's the per protocol SVR. If we look at a TED to treat, that's obviously going to include all those people who were lost to follow-up as well. Now, granted, there are probably a lot. So those 31 people that the last time we saw them, they were undetected. Most of them are probably cured. But if we can't get them back in under that very strict definition of SVR, we can't say that they're cured. So it's probably a little bit higher as well. And again, from a public health perspective, we know that there are additional, 31 people out there, likely about 31 people out there who are no longer transmitting. So for us, that's a win. So the women in our study tend to do a little better. The older folks tend to do a little better. And not surprisingly, people who inject drugs, their SVR rates aren't as high. But these are people who are injecting meth multiple times per day, and we're able to get 80% of them through treatment. I think that's a win. That's a huge win. And again, if we're doing some mathematical modeling, we're going to be able to look to see how many potential infections are averted from treating this very population. The reinfection rates are really low. That's also a concern. So you talk to providers and they're like, I don't want to treat someone who's actively using drugs because they're just going to get reinfected. Well, so far we've had 6 people out of 250 reinfected. That doesn't, you can't say that about everybody, that everyone is not just going to get reinfected. And then at 12 months, we only had 1 additional reinfection. So we're doing pretty well with reinfections thus far. How are we doing with community viral load? Well, I'm going to eventually have lab data from pre, during, and post. So basically every positive lab, hepatitis C RNA lab is recorded at the state level. So we'll be able to actually look to see if there are reductions in the community viral load, basically by the proportion of infections that we're able to detect over time in the lab data. But this is just looking at the people that came in, because we do hepatitis C testing on everybody, right? We do antibody and RNA testing on everyone. It took us basically twice as long at the end of the study to find viremic individuals. So to me, that says, hey, I think we're potentially reducing the number of people who are infected in the community, reducing that viral load. So at the end of the day, I think we've been pretty successful in recruiting, treating, curing rural residents infected with HCV. And from my perspective, again, really targeting those who are using and injecting drugs is of the utmost importance if we're going to think about elimination. Our per protocol SVR rates are excellent and our reinfection rates are really low. We also allow folks to do what we call restarts. So basically, they're lost to follow-up. We don't see them for a year and they show up at our door. You guys, if you do research with people who use drugs, oftentimes they will drop off the face of the earth and then they reappear. And they say, I'm ready to start over. And we say, great, let's do it, you know? So we've had 61 individuals. Also, some of those people who were reinfected or who didn't achieve SVR, who were undetected at the 12 weeks, but then came back for their SVR visit and they were detected again. We restart those. Everybody who has come in who we've detected has wanted to restart the medication, and we've gotten a lot of them successfully through the treatment. Got some very sort of preliminary evidence for reductions in community viral load. But for me, again, from a public health perspective, when we first started the study, we could not find one person to partner with in the community. That's why we have our own clinic, because there was not one provider who wanted to touch this population. So we literally had to hire our own nurse practitioners. We had to have, no one would allow us to co-locate in their practice. And the syringe program wasn't big enough. And then the people in the syringe program didn't want to go to the MOUD clinics. We probably could have partnered with them, but then, and then the people in the MOUD clinics didn't want to go to the SSP because they said it would be triggering for them. So like, we ended up having this neutral location, but really we would love to partner with a local clinic. No one wanted to do it. So in the meantime, they've seen people who have been cured. This, again, small community, everyone knows everybody. And they've seen the success that we've had, including people who inject drugs and getting them through the 12 weeks of treatment and getting them cured. So now there's money to be made in hepatitis C treatment, and they're seeing that, hey, maybe this population is someone that we can actually treat. And so we anticipated 500 to 900 people. We ended up with 380, and that's because other providers are picking up the slack, and we welcome that. You know, at the end of the day, our statistical power took a little bit of a beating, but that's not what this is about, right? This is about reducing the community viral load, and that's an all hands on deck situation. It's not just us, it's all of the providers in the community. So I think of it as a good thing. Again, the biostatistician in me, sometimes it gives me anxiety, but the public health person says this is exactly what we wanted to happen, because we're going to have to pack up and leave, right? Because we are federally funded, we're grant funded. And so we're hoping, you know, while our clinic is not sustainable, we're hoping that we'll be able to take the lessons learned from our study and pass it on to the local providers in the community and other providers in under-resourced areas. So, you know, lessons learned, we've been doing this for a while. We're at the tail end, we've finished recruiting. Transportation is just a huge issue. If you actually look, I have a whole paper, I'm looking at loss to follow-up, and transportation is by far the biggest factor, right? So 40% of the people who aren't lost to follow-up have access to regular transportation versus less than 20% of those who were lost to follow-up. So, and then everyone's like, oh, telehealth, great. So Echo, you guys have probably heard about Echo. It's great. It was actually developed to do rural hepatitis C. But, one of the big initiatives that President Biden has undertaken as part of his presidency is to increase broadband access. When he's talking about increasing broadband access, it's in this area. Like, this is the area where there is no, our office doesn't have broadband. We don't have broadband in our office. We have dial-up in our office, basically. So having, it takes a certain level of, of technology and and people being able to utilize technology, and then broadband access to be able to do a reasonable telehealth visit. It's just not possible right now. Hopefully that will change. So we have to think about how we can minimize the number of visits, get people started. We need to minimize. So if they need to go to the lab, they need to go to their clinic visit, and they need to go to the pharmacy. That's 3 different rides that they potentially have to get. How can we potentially put that all in one place? So do we maybe have a mobile unit that goes and parks at pharmacies, so then we can just walk them into the pharmacy? We can have a mobile lab. We can do other services. So I think that it's probably too much to ask for each community to have its own, standalone hepatitis C clinic. So ideally, if we can co-locate services, or that some of the primary care providers will say, hey, this is something I'm interested in doing. Right now, most of them in rural communities are so overwhelmed. There are a lot of other health issues in these rural communities, obesity, cancers. Most of the time, they don't detect cancers until far later in these rural communities. And just, diabetes, chronic health conditions that they're like, I just can't add something else to my plate. So right now, one of the issues is getting folks to want to add this on to their repertoire of services. I think the only way to do this is if we have access to point of care RNA testing. That's one of the big pushes. So I'm going to end with how potentially the results from this study fits in with the new national HCV elimination plan. So Francis Collins was the head of NIH. He has since stepped down from that position, and he's been asked by the Biden administration to head up the national HCV elimination plan. And they presented last year at the liver meeting, and what they talked about was the first and foremost is getting RNA testing into the hands of providers in non-traditional settings too. So if you think about this, if you're able to put this this piece of equipment in, say, a syringe services program, you could potentially, antibody testing, that's what they do right now. It's good, but it doesn't mean they're chronically infected, doesn't mean they're treatment eligible. And they've had it a million times at this point. Like, it's just, it doesn't have the same effect anymore. So being able to tell them, hey, you're treatment eligible, and potentially hand them off to a treatment provider is huge. So ideally, we're hoping that at least some of the pieces of this study can fit into, when we're thinking about models of care, through Medicaid. They're also hoping to optimize Medicaid coverage across the country and harmonize that. Right now, there are different barriers in different states. Some have no restrictions on accessing treatment, some have a ton of restrictions. So harmonizing that, so they're working with CMS to hopefully have a universal program, and then potentially doing a drug buy like they did in Australia. Australia just worked with Gilead and basically spent $5 billion and bought enough drug to treat the entire country. So I think that's kind of the model they're looking at. Can we potentially buy it as a country, and then the different Medicaids can purchase it and make it available? So there's different potential ways in which to do that. So and hopefully our modeling will also, so if, we are obviously going to be providing all the parameters for this mathematical model. So we have an SSP, we had point of care RNA testing, et cetera. But if you're a community a couple states over, you don't have an SSP, well, you can kind of take that out of the model, and then you can say, okay, well, this is a number we need to treat to hopefully eliminate the virus in our community, given that we have some of these things, but not all of these things. So hopefully we'll be able to tailor a little bit of the model to different communities just based on the resources that they have available. Some are going to have more resources than others. And in the South, we have a lot of states that don't have any harm reduction services available. So we are at an advantage in that we certainly have harm reduction available to us. So we're hoping to kind of provide some data to the national HCV elimination plans at different stages as they kind of move along and gather in data to formulate a national plan, because we're one of the only industrialized countries that doesn't have an elimination plan at this point. And the WHO plan is fantastic, but most of the time, most of the European countries have very different health systems than us, and it's kind of predicated on having this, socialized medicine that we just don't have access to here. So we're kind of having to go at it in a little bit of a different way, and certainly, unfortunately, insurance is going to be the biggest barrier to that really they aren't facing in many other countries. So with that, I'd like to acknowledge NIH and the really kind of interesting funding, the way this is funneled through NIDA and NCI. I think their first ever collaboration, which is kind of fun. And then Gilead for donating millions and millions of dollars worth of drug to us at this point, free of charge. And our amazing participants and our team who have just tell us all the time that this is the first job they've had that they feel like they're actually doing something, which is really amazing. From my point of view, and it's, being an epidemiologist, oftentimes I gather the data and hand it off to somebody else and say, hey, can you do something about this? Maybe. So this is the first time I've actually been able to take some data and say, hey, let's try to do something about this as a team and hopefully address an issue that is come about as a result of drug use. So I'm happy to take any questions about